Here we're coming to continue with the hematopoietic and lymphoid module pathology lectures, lecture 3 and 4. Lecture 3 and 4, the objectives include thalassemia syndromes, that include alpha thalassemia and beta thalassemia, the characteristic features of the peripheral blood film of each one of them, and the prevalence of the thalassemia and the bone marrow finding in thalassemia, the diagnosis and the treatment. The other type of the anemia is G6PD, glucose 6-phosphate dehydrogenase deficiency, FABism, iron deficiency anemia, when there is defective in the erythropoiesis because of the deficiency in the iron, megaloblastic anemia due to the deficiency of the vitamin B12 or folate, autoimmune hemolytic anemia, paroxysmal nocturnal hemoglobinuria, and aplastic anemia. All of these type of anemia will be covered in this lectures. Thalassemia syndromes. Thalassemia syndromes are heterogeneous group of inherited disorders caused by mutation that decrease the rate of synthesis of alpha or beta chain of the globulin. In hemoglobin, we said that there is heme and the globin. When there is defect in the synthesis in one of these two components, it will lead to development of anemia of certain types. When there is decrease or there is defect in the rate of the synthesis of alpha globin chain or beta globin chain, thalassemia syndromes develop. It can be of two types. Alpha thalassemia. What is the meaning of alpha thalassemia? Alpha thalassemia mean the deficiency in the synthesis of alpha globin chains. From the name, alpha mean there is deficiency in the synthesis of alpha globin chains. Beta thalassemia mean there is deficiency in the synthesis of beta globin chains. So, when there is deficiency in one of these chains, either alpha or beta, it will lead to the deficiency of the hemoglobin. It will lead to the defect in the hemoglobin synthesis with additional secondary red blood cell abnormalities that caused by the relative excess of other unaffected globin chain. Alpha thalassemia. What is alpha thalassemia? Alpha thalassemia basically are a group of disorders that characterized by decrease in the synthesis of alpha globin. The molecular basis of the alpha thalassemia is different from that of the beta thalassemia. We are coming now to know what's the difference in between. Because most of alpha thalassemia are caused by deletion of one or more of the alpha globin gene loci, and the severity of disease depend and directly proportional to the number of the alpha globin gene that are missing. So it is classified into 4 types. We have 4 types of alpha thalassemia. First, thalassemia minor, القليلة, also called silent carrier, when the patient missing only one functioning alpha gene, but we have other one. So, the 3 remaining alpha gene direct the synthesis of adequate number of alpha chain for normal hemoglobin synthesis. We have here, it is silent carrier. We miss in thalassemia minor only one functioning alpha gene, but in other hand, we have remaining 3. So it will direct the synthesis of the adequate number of alpha chain in the normal hemoglobin synthesis. Therefore, this patient that are silent carrier, that missing only one functioning gene, have no clinical manifestation of hemoglobinopathy, because the remaining three alpha gene can direct the synthesis of adequate hemoglobin. In such a case, the patient only become or called basically it is silent carrier. No clinical manifestation of hemoglobinopathies. The other type of thalassemia, alpha thalassemia, we have alpha thalassemia trait. In such a patient, basically we have two missing alpha genes. In such a case, this will lead to the excess beta chain would join in tetrad form, beta 4. The patient in such a case have mild to moderate microcytic hypochromic anemia. So the clinical symptoms of such a patient, it's just mild anemia. When we do blood film for such a patient, we just see and we just find that the patient have mild to moderate microcytic hypochromic anemia. Here we are coming to the alpha thalassemia major, when we have deletion of 3 functioning alpha gene with excessive hemoglobin H, beta 4. So it is called hemoglobin H disease. This hemoglobin H has high affinity to oxygen, 10 times the affinity of hemoglobin A, but it cannot transfer oxygen to the cell properly. This is hemoglobin H disease, in which there's deletion of 3 functioning alpha genes. Okay, this hemoglobin H, you have to remember, is that it is high affinity to oxygen, but more than hemoglobin, but cannot transfer enough oxygen to the cell properly. These cells have reduced lifespan because of the damage of the cell wall by precipitated hemoglobin H, and subsequently it will phagocytose in the spleen. Hemoglobin H disease. What is hemoglobin H disease? It's chronic, coming to the point, chronic, moderately to severe hemolytic anemia, more common in Southeast Asia. The hemoglobin level, HB level, range from 4 to 10 gram per deciliter. Mean corpuscular volume, MCV, mean corpuscular hemoglobin, mean corpuscular hemoglobin concentration, MCHC, are all decreased. Patient has anemia. Clinically, patient have anemia. Hemoglobin electrophoresis will find or reveal that hemoglobin H 4 to 30% of the total hemoglobin, so it is high. Now we are coming to the hydrops fetalis, which represent basically a state of the 4 deletion of alpha gene. All the alpha gene are deleted. So there is excess in the production of gamma globin of the hemoglobin F. This is called hemoglobin bars, gamma 4. This lack of alpha chain production is incompatible with life. The patient or the baby cannot is incompatible with life. It cannot born alive. So the affected fetuses die either in the utero or shortly after birth. This is hemoglobin A. Look at alpha 2 and beta 2. When there is decrease in the alpha 2, so it's beta 4 hemoglobin H, and this is a hydrops fetalis, in which there is gamma 4 hemoglobin bars, which is incompatible with life. The fetus either die in utero or die shortly after birth. This is a blood film in patient with alpha thalassemia. We have in the alpha thalassemia, we see anisopoikilocytosis with the marked high number of target cells. This is the target cells, This is when there is central, dark central dot because of the accumulation of the hemoglobin in the central of the cells with normoblast, or called nucleated RBC, which, which shouldn't have been seen in the blood form. This is Hydrops fetalis. This is a fetus presented with alpha thalassemia. 4 alpha gene are deleted. It is gamma, Bart's hemoglobin. So this fetus is incompatible with life because his hemoglobin, he has deletion of the 4 alpha genes. Here we are coming to the second type of thalassemia, is beta thalassemia, in which the beta globin mutation associated with the beta thalassemia fall into 2 categories. The first one, beta O, in which no beta globin chain are produced. There is no beta globin chain at all. And the second one, when beta plus, in which there is reduced amount of the beta globin synthesis, but it is detectable. The individual then inherit one abnormal allele, have thalassemia minor, or it's called thalassemia trait. Those patients, basically, they are asymptomatic or mildly symptomatic. Most patients that inherit any 2 beta O and 2 or beta plus allele, 2 allele, they inherit 2 allele, mutation in 2 allele, have beta thalassemia majors. Occasionally, individuals that inherit 2 beta plus allele have mild disease termed beta thalassemia intermedia. This is a beta thalassemia. This is an adult hemoglobin. When there is mutation in the beta globin, so we have alpha aggregates. The consequence of reduce in the beta globin chain production, if there's in the both of them, it will lead to the thalassemia major. Is only one of them, it lead to the development of the thalassemia trait or thalassemia minor, which is very common in our community. As a consequence of beta thalassemia, when reduction of beta globin chain, it will lead to the ineffective erythropoiesis. Why? Because the hemoglobin defect in the hemoglobin and the lifespan of the red blood cell are short, so it will lead to the anemia. Anemia, it induces the bone marrow ineffective erythropoiesis, which lead to the anemia, iron overload, and erythroid marrow, which is expansion, and spleno. This is another slide, peripheral blood film which show thalassemia major. It is showing anisopakelocytosis in which the size of the cell are different and the shape of the cell are also different. What does that mean? The size, look at here. This is a small size, and this is a normal, and this is a large. This is anisocytosis. While the shape of the cell also are different. This is look like teardrop shape. This is also teardrop shape. This is also. However, there's other red blood cell showing normal shape or about to be normal with hypochromia. There is marked hypochromia in patient with the thalassemia major. This is also another blood film in the thalassemia major, which showing marked anisopoikilocytosis. There is marked variation in the size, حجم الخلايا, and the shape of the red blood cell, وشكل الخلايا. That's mean there are different size. Look at here. This is small size. This is normal size. This is a bit large size. So there is different variation, marked variation. Most of the blood film showing the same picture. The shape of the cell also normocytic. Some of them are normocytic, normal looking cell. Many of them actually are elliptocyte and ovalocytes, showing the other cells maybe teardrop shape. Where is the teardrop? Let me This is abnormal looking. Actually, this is a target cell. So this is a teardrop, a red blood cell. So this platform showing marked variation in the size and shape of red blood cell. Actually, this is on one of the slides that you can give the diagnosis or differential diagnosis without any clue. When I give it to you in the practical exam, I will ask you what is the most possible or probable diagnosis when you examine peripheral blood film like this one. I wouldn't give you any clue. I wouldn't give you the history because as soon as you have checked this peripheral blood film, you have to know that this is an nesopoikilocytosis. There's marked variation in the size and shape. Most probably, the most possible diagnosis is the thalassemia major. This is thalassemia minor. If you compare between two blood film, you will check or you will find there is marked difference in between it. In this case, you will see only hypochromic normocytic because the size of the cell are about to be normal. Hypochromic normocytic with the nucleated RBCs and target cells. There are more than one target cell in this blood film. The first type of the beta thalassemia is beta thalassemia minor. What is the meaning of beta thalassemia minor? Actually, it is the most common form of thalassemia. It is the type of the thalassemia that commonly affect the individual in Mediterranean countries. Therefore, it is called فقر دم حوض البحر الأبيض المتوسط because there are many people in those area, in those country around the Mediterranean Sea that are thalassemia minor patients or people because they are not pure patient because they don't have a symptom. Most of them are asymptomatic. Other countries as Southeast Asia and Africa are also have the same disease. Those patients are different from the beta thalassemia major, which are homozygous. Here it is heterozygous. They are asymptomatic. There is no symptoms. However, they have mild anemia. Therefore, those patients might be not diagnosed as being thalassemia minor carriers or thalassemia minor people unless doing complete blood picture and the doctor advised to do peripheral blood film for any reason, for checkup, or he might found the patient a bit pale, or the patient is pregnant and she had to do investigation in early pregnancy. So he sent them to the laboratory and then the result show that the patient, by examination of the peripheral blood film, have hypochromic microcytic anemia. The internist or the physician or GP will think that this patient have hypochromic microcytic anemia. What are the causes beyond hypochromic microcytic anemia? Actually, they are the main cause of hypochromic microcytic anemia. What is it? Is iron deficiency anemia, which is very common among poor communities, and not only poor communities. There are in some communities that are not prefer to have meat or good green vegetables. So, iron deficiency anemia are common in our communities. He will suspect the patient might have iron deficiency anemia. He will send him to do serum ferritin and serum iron or serum iron binding capacity according to the indices that he would like to know. But he should also, especially if the patient from this Mediterranean country, he should also think about thalassemia minor because the patient might have thalassemia minor, which is very important to know. Okay, so what he will do in addition to the hemoglobin, serum iron and ferritin, which is the iron stored iron in the body, he should do hemoglobin electrophoresis in order to know what is the types of the hemoglobin in this patient. The abnormalities so are confined to the peripheral blood film, which show hypochromic microcytic and the red blood cell regular in shape, almost they are regular, not as marked anisopoikilocytosis that have seen in the peripheral blood film in patients with the thalassemia minor. The target cells are also seen. In such a case, when there is hemoglobin electrophoresis, we have seen that increase in the hemoglobin A2, while hemoglobin F might be normal or mild increase. This is the peripheral blood film in the patient with beta thalassemia minor, in which the size it is a bit mild hypochromic. Look at this is a normochromic. This is a normochromic, while here there is hypochromic. This is faint looking hemoglobin because there is low hemoglobin in such a patient. Target cell are seen. This is normochromic looking, and this is a bit hypochromic. This is hypochromic, and because of the low level of hemoglobin in the red blood cell, so it is seen, or it is hypochromic. Target cell are seen also, and this is a nucleated RBC. Why there is a nucleated RBC? Because in such a case of anemia, there's erythroid hyperplasia in order to compensate the low hemoglobin or the low hemoglobin or the destruction of the hemoglobin that takes place because of the abnormal hemoglobin that are present in the cell. So the shifting of the nucleated RBC, which should be seen only in the bone marrow. While in beta thalassemia major, it's also affect the individual in Mediterranean countries and part of South Asia and Africa. Most of these patients inherit any two beta O or two beta plus allele which have beta thalassemia major. Those patients are homozygote. Usually the anemia in such a case is manifest at 6 or 9 months after birth as the hemoglobin switch from the hemoglobin F to hemoglobin A. Unfortunately, this type of the thalassemia major take place and occurs in the families when the marriage in between relatives is at the high rate, and not also in the families, but because there are many carriers in the community. Many have thalassemia minor. So if one thalassemia minor marry other one thalassemia minor, so they are high. The percentage or the possibility and the risk to have a thalassemia major baby is very high. Therefore, this is the point that to do the investigation before getting married. فحوصات ما قبل الزواج, it is very important. Pre-marriage laboratory test to do at least complete a blood picture in order to just examine the peripheral blood in order to exclude that each one of you might have microcytic hyperchromic anemia. In suspected cases, we do hemoglobin electrophoresis to exclude the thalassemia minor in one of the partner. Otherwise, if this is neglected and the thalassemia minor with the thalassemia minor, it will get big problems because one of the baby will get thalassemia major, and this is one of the most disaster actually medical situation that the family will suffer from this problem in the future, because affected children fail to develop normally, and we will come to this retard in development and the growth in the next slides. In untransfused patient, the hemoglobin level range from 3 to 6 gram per deciliter. With a transfusion, survival into the second and third decades is possible, but gradually the patient that have repeated transfusion will have problems because he will develop iron overload, hemochromatosis, the ferritin level is very, very high, and it might lead to the heart failure, cardiomyopathy, and subsequently lead to death. The morphology. In beta thalassemia, the bone marrow is hypercellular and showing erythroid hyperplasia, while in the peripheral blood film showing microcytic hypochromic red blood cell with variation the size and the shape of the red blood cell, the variation in the shape called poikilocytosis, while the variation in the size called anisocytosis. We will see also target cells and the appearance of immature nucleated red blood cell called nucleated RBC or normoblast, as well as increase in the count of reticulocytes. This figure showing blood film in beta thalassemia major, which showing in, if you remember the beta thalassemia minor, it is just microcytic hypochromic anemia RBCs. Here there is anisopoikilocytosis, cherry drop, some of the, this is a target cell, this is a typical target cell. This is actually one of the slides that educational and for spot diagnosis. When we, if we put a row here, this is a target cell. Let me make a row. This is a target cell. Just a minute. This is a target cell. So this is if given in the exam. Let me just a minute. Raise it. It's not. Make it again. Put it the pen. Just a minute. This is a row. This is a target cell. I will not erase it. So this is a target cell. This is a teardrop cell. Look at the size. This is RBC is very small. So there is anisocytosis. Variation in the size. Look at it. Variation in the shape, poikilocytosis. Look at this. Is different shape from this one and is different from this one, which is the target cell, and different from this. This is a full blood film in beta thalassemia major. Other film, blood film in severe beta thalassemia major. This is it's marked anisopoikilocytosis, marked nucleated RBCs are seen. This is a nucleated RBCs are seen. This is nucleated RBC. This is a nucleated RBC. This is a nucleated RBC. This is a bone marrow which show erythroid hyperplasia, increase the number of normoblasts, increase the number of progenitor of erythroid series because of the hemolysis, because of hemolytic anemia. So the bone marrow try to compensate the destruction of red blood cell, the lack of the red blood cell because of defective of the hemoglobin. So there's a patient has anemia, therefore increase the production of red blood cell in the bone marrow. So it show erythroid hyperplasia. The pathogenesis. The pathogenesis, basically, while alpha globin chain, we say that in the beta thalassemia there is defect in the beta globin synthesis. So there is alpha globin chain continue to unimpaired, most of the chain remain free because they don't have complementary beta chain to bind. No beta chain in the beta thalassemia. The free alpha chain, what will form? They form highly unstable aggregate, which precipitate in the normoblast in the form of insoluble inclusion. What will happen then? It will cause cell membrane damage, which lead to the potassium loss and impairment of the DNA synthesis, resulting in apoptosis of precursor cells within the bone marrow and the phenomena called ineffective erythropoiesis. You know, there is production of the bone marrow, increase the production of the bone marrow, but the production is ineffective because this free alpha chain, which form highly unstable aggregate, what precipitate in the normoblast. So it will lead to the damage to the cell membrane, lead to the potassium loss, impairment in the DNA synthesis, apoptosis of the precursor cells inside the bone marrow. So what is the result? That it's ineffective erythropoiesis. About 70 to 8%, 85% undergo, the normoblast undergo apoptosis in severely affected patient. The bone marrow is producing, but it's lost. Apoptosis, die. You know, it is pathological, it is physiological, there is death. There is no death of the in such a case because there's impairment in the DNA synthesis, so there is pathological death of the if you remember that apoptosis, death of the normoblast. So the patient still have severe anemia because the erythropoiesis in the bone marrow is ineffective. Inclusion bearing cells that can leave the bone marrow are sequestrated and destroyed in the spleen. The ineffective erythropoiesis and red blood cell hemolysis. This will lead to the stimulation of erythropoietin secretion, which lead to the severe erythroid hyperplasia. So, when there is severe erythroid hyperplasia, it will cause skeletal deformities. Why? Because when there is erythroid hyperplasia, there is expanded hyperplastic marrow. When there is expanded hyperplastic marrow, it will invade and resorb the bone. It will lead to the bone resorption, which give appearance of hair on end, as in the skull. Also, there is delay of the bone growth. Hair on end, the same things that we have seen in sickle cell anemia, because it is caused by erythroid hyperplasia, the effect which cause skeletal deformities. Subsequently, there is ineffective erythropoiesis. There is extramedullary hematopoiesis, which where it is occurring in the liver and spleen, which lead to the splenomegaly. It's about 1,500 gram, and hepatomegaly. There is hepatosplenomegaly, enlargement of the spleen and liver. The other disastrous, the other harmful effect, the other bad things that happen to the patient because of there is excessive hemolysis of red blood cell lead to their excessive absorption of iron together, because in addition to the red cell hemolysis, there is frequent blood transfusion which is given to the patient in order to in order to increase the level of the hemoglobin. This will lead to the secondary hemochromatosis due to the increased iron overload, because the patient have much blood transfusion, frequent blood transfusion every now and then, with the destruction of RBCs, which lead to the excessive load of the iron, both causes it will lead to the increase in the iron overload. The iron is not excreted from the body. It will be precipitate in the deposit in the liver, deposit in the pancreas, deposit in the eye, deposit in the different tissue of the body. Progressive hemochromatosis, or in the heart, progressive hemochromatosis is one of the important cause of death in such patients. We are coming to the pathogenesis of beta thalassemia. Basically speaking, that beta chain not produced in the beta thalassemia. So, consequently, alpha chain will accumulate in the normoblast. When it accumulates, it will cause damage to the cell membrane, which lead to the destruction of normal blast in the bone marrow. So, however, the bone marrow produce large number of normoblast, but it is ineffective, not working. It is ineffective erythropoiesis. It will lead to the anemia. When there is anemia, so oxygen carrying capacity of the red blood cell decrease, which lead to the hypoxia in the tissue. As a result of hypoxia in the tissue, the erythropoietin, it will produced by the renal cells, which what will lead, because there is ineffective erythropoiesis and erythropoietin increase, it will happen. What will happen? There's extramedullary hematopoiesis. Extramedullary hematopoiesis, which lead to erythroid hypoplasia. Erythroid hypoplasia, it leads to the widening or expansion of the bone marrow space, which will lead to the resorption of the bone and bone changes. Therefore, the patient with the thalassemia major showing the face is prominent of the cheekbone. In addition to the anemia, it will lead to the cardiac failure and then to the death. The cardiac failure may be due to the anemia and may be due to the other cause, iron hemochromatosis or hemosiderosis actually, because the position of the iron, which is due to the destruction of RBC first, and second because of the repeated blood transfusion in patient with thalassemia major. It will lead to the iron overload, here secondary hemochromatosis, which is the main cause of cardiac failure and death in those patients. This patient have thalassemia major, and what is here? It is splenomegaly actually. This is a spleen. Look at his abdomen, the distended abdomen because of the spleen. The spleen actually reaching below umbilicus. When look at it, this is a line, and this is the spleen reaching below umbilicus. It is really very large spleen. This is a gross appearance of the splenomegaly in beta thalassemia major. It's actually very huge spleen. Most of those patients undergo surgery to remove the spleen. Very large spleen. Very large spleen actually. This is the hands of the patient with it is bronze looking because of the hemochromatosis due to the repeated blood transfusion. So there's patient have hemochromatosis in patient with beta thalassemia major. The diagnosis regarding the beta thalassemia minor, basically the diagnosis made by hemoglobin electrophoresis, which is very important because the patient clinically presented with anemia or just visit the doctor for any other reason. He did complete a blood picture by peripheral blood film. The hematologist see that he has macrocytic hypochromic anemia, so advice for the further investigation, which is hemoglobin electrophoresis. In electrophoresis is revealed that the hemoglobin amount of the hemoglobin A reduced, alpha 2 and beta 2, while the level of hemoglobin A2, alpha 2 and delta is increased. While the beta thalassemia major, the clinical feature of the patient is obvious on the face. Especially, we said that in hemolytic anemia, because there is erythroid hyperplasia, which lead to the expansion of the bone marrow space, which lead to the resorption of the bone. At the same time, new bone formation, so the appearance in the face of the patient make the patient render him to be so the feature is so obvious on a clinical ground, so the doctor can diagnose it and then confirm the diagnosis also by the hemoglobin electrophoresis. Prenatal diagnosis of both forms of thalassemia made by the DNA analysis of amniotic fluid at 12 and 14 weeks of gestation. We are coming now to the other type of anemia, which caused by G6PD deficiency. Glucose 6-phosphate dehydrogenase deficiency. The red blood cell usually is vulnerable to be injured by various types of exogenous and endogenous oxidants, which is normally inactivated by glutathione, GSH. So any abnormality, any disease, any mutation that affect the enzyme that is important for the production of glutathione make the ability of the red blood cell to be reduced to protect themselves. So the red blood cells are no longer be protected by itself. When there is oxidative injury, lead to the hemolytic disease because there is nothing to be protected. There is no glutathione production because of the abnormalities in the enzymes that are important in the production of this glutathione. The prototype of this anemia is associated with G6PD. This renders the red blood cell more sensitive, more vulnerable to oxidant stress, which then lead to the hemolysis. The deficiency of G6PD basically is X-linked inheritance of a mutant gene. That means red blood cells of the male are affected. It is X-linked. Because the heterozygous female have two red cell population. Some of them are normal, others are G6PD deficient. So they are carriers. They can carry or run the disease in there or carry the disease or transfer the disease into their offsprings, into their male, while the female mostly protective. Why? You know, the female is XX. So one of the X is diseased, the other is normal. So the type of the RBCs, two types of the red blood cell population in the female. نص طبيعي والباقي G6PD. So it is asymptomatic carriers. لكن لما الفيميل carrier يصير عندها ولد، ممكن واحد من هذا الولد إذا أعطته الإكس كروموسوم الديزيزد إكس كروموسوم حيصير مريض because it is X-linked inheritance. So what is the oxidative injuries that when the red blood cells or when the patient with G6PD exposed to caused hemolysis? There are certain important injuries or factors or agents that lead to hemolysis. A drug, antimalarial, primaquine or chloroquine, which is now is the most important, that chloroquine, the antimalarial that are think that is important or it is maybe working in some patients. Of course, it is just a trial. There is nothing proved yet that COVID-19 patient, infected patient might get benefit of this antimalarial drug. This is it. Or certain type of the drugs, sulfonamide, nitrofurantoin, phenacetin, aspirin in large doses, vitamin K derivatives. All these drugs are cause oxidative injury to the red blood cell in patients with G6PD. Certain type of infection, pneumonia, viral hepatitis, typhoid fever. So the episode of the hemolysis is triggered by phagocyte, which induce free radical as a part of normal host response. The most common cause or the exudative injurious agent that is commonly used in the community that lead to the hemolysis in those patients with G6PD are fava beans, الباقلاء, الفول. When ingested by those patients, it will lead to the hemolysis. لهذا يسموه التفول. مرض التفول اللي يأكلون الفول ومش بس الفول الchickpeas الحمص any type of the البقوليات in general it will lead to the hemolysis in the patient with the G6PD. Here we are coming to the pathogenesis of the G6PD. When the red blood cell injured by the oxidative injury, it will lead to the oxidation of sulfur hydryl group of globin chain. This will lead to denaturation of hemoglobin. When denaturation of hemoglobin takes place, it will lead to the formation of a precipitates, which is called Heinz body. This is Heinz body are seen in G6PD, in the red blood cell of G6PD, which can be seen within the red blood cell as dark inclusion, نقاط سوداء, when stained by special stain, crystal violet stain. This is important to be memorized. These precipitates make damage to the membrane, which lead to the intravascular hemolysis. So in G6PD, there is intravascular hemolysis. In addition to extravascular hemolysis that take place out of the circulation. Why? Because his bodies reduce red cell deformability. So the inclusion-bearing red blood cell, when passing through the splenic cord, the macrophage will pluck out تخمطها and bite it. This Heinz body give rise to the bite cell. The appearance of the red blood cell look like bite cell as a part of the cytoplasm is bitten. And the cell then phagocytosed by the macrophage, which lead to the extravascular hemolysis. Clinically, the patient, when exposed to any oxidative injury, such as when he intake a drug, antimalarial, aspirin, sulfa, exposed to the infection, pneumonia, whatever, have ingested fava beans or any related food related to the fava beans, البقوليات. It will lead to the intravascular hemolysis. If we get back to the feature of intravascular hemolysis, which is characterized by jaundice, yellow discoloration of the skin and sclera, anemia, فقر الدم, because there is hemolysis, destruction of RBCs, hemoglobinemia, because it is intravascular hemolysis, so it will lead to the hemoglobinemia, hemoglobinuria, because excreted in the urine, usually begin 2 to 3 days following the exposure to the oxidant. The hemolysis tend to be more in highly unstable Mediterranean variants, and it involve older red blood cell. But it is self-limited because it stops when only young red blood cell remain, even if the use of the drug continue. Only involve the older red blood cells. General features of chronic hemolysis like splenomegaly and cholelithiasis are absent because it is not acute chronic hemolysis, it is acute intravascular hemolysis. This is a picture of the patient with the male patient kid that have the jaundice because he has G6PD. Actually, most of the patients, as we said, they are X-linked inheritant, because it is the disease is X-linked, that it is carried in the X chromosome. Therefore, when the disease X chromosome inherited by the male, so it will be diseased, no carrier in the male. However, in the female, because it is XX, so it would be carriers. However, some of the females, according to my experience, there are some of the female who is carriers who are this disease run in their families and they carry the X disease might have hemolysis. So if she is a female and carrier, don't feel that she wouldn't have the hemolysis in her life. No, sometimes in some circumstances when the ingestion of the high amount of the fava beans, I prefer in the families that have this disease is run, avoid, even the females should avoid the drugs that oxidant injury, because should tell her doctor or internist or a physician that aspirin, nitrofurantoin should be avoidable, and antimalarial in order not to, because it might get hemolysis. So it's nothing impossible. So those patients when ingest large amount of fava beans or green peas, البازيلا أو chickpeas, الحمص أو white beans, all the beans should be avoided, all should be excluded from their food. Otherwise, and even the season, in the season, sometimes the smell of the fava beans when boiled or when cooked should be avoided, actually, in the houses of such a patient, because even those might lead to the sort of hemolysis. When there is hemolytic crisis, and so in those patients, they are living normal life unless they are exposed to this injurious oxidant or the ingestion of the large amount of food, which lead to the intravascular hemolysis, which lead to the jaundice, severe jaundice, and severe anemia. Abrupt reduction in the hemoglobin actually take place in the crisis. So sometimes those patients, of course, withdrawal of the drug or of the should be done, but that the hemolysis in such a case is already happened. So sometimes those patients need blood transfusion because of the reduction of the hemoglobin is so severe, because the destruction of red blood cell is so severe, and especially in the crisis. So those patients should avoid this sort of food or the types of the drugs that considered as an oxidant to them, which lead to the hemolysis. I don't know what is this. Do you know it? It is fava beans. Yes, I think it is delicious. Actually, it is delicious item of food, and it's very very healthy because it's contain contain vitamins, contain protein, but unfortunately, those patients with the G6PD deficiency should avoid it because it will lead to the intravascular hemolysis. So they should avoid it. This is a hen's body. Look like at hen's body. Bicrystal violet, hen's body. This is a grain's body, denaturated, which represent denaturated hemoglobin, which is precipitated in the red blood cells and cause damage. This is a hen's bodies, which is a feature of the red blood cell that are seen in patients with a G6. What is this? As we said, these red blood cells that are plucked out by the macrophage. This is a hen's bodies, upper left corner, and this is a bite cell. Where we should see, where would we see this, where would we find this cell? We would find them in the peripheral blood of the patient with G6PD. We are coming to the other type of anemia, which is immune hemolytic anemia. What is the meaning of immune hemolytic anemia? Basically, some of individuals develop antibody against red blood cell membrane that lead to the hemolysis. These antibodies might be exogenous, might be drug. Any type of a drug might lead to the hemolytic anemia in susceptible patient, or maybe due to the chemicals, might be due to the certain infections, certain autoimmune disease. We have warm type hemolytic anemia and cold antibody hemolytic anemia. We will get through these two soon. Warm antibody hemolytic anemia is caused by what? IgG or IgA antibody at 37 centigrade. It may be idiopathic, maybe of unknown cause. No identified cause. There is we don't have any obvious cause that might lead to this hemolytic anemia, immune hemolytic anemia. Just the patient might develop IgG and IgA against his RBCs, or might be due to this secondary to the certain disease, might be infection, SLE, systemic lupus erythematosus, or drugs, as example, methyl dopa. This induced autoantibody against Rh blood group, penicillin, and quinidine also may act as haptin or opsinin that enhance RBC phagocytosis. So this hemolytic type of anemia might induce antibody or might act as haptin 2 or opsinin that lead or to attract the phagocytes in order to destruct red blood cell. The other type is called antibody hemolytic anemia. It is caused by low affinity IgM antibody, but this is bound to the red blood cell membrane at low temperature, below 30 centigrade. The hemolysis in such a case occurs in the hand and feet and in the cold weather. And when this happened, it is happened during, or it's seen. Where could we see this case of cold antibody hemolytic anemia? In maybe during the recovery from mycoplasma pneumonia. Here you are coming to the paroxysmal nocturnal hemoglobinuria. Actually, this is a rare disorder, and being the only anemia, hemolytic anemia, which results from acquired somatic mutation in myeloid stem cells. Basically, this mutation takes place in the gene of PIGA. This gene is required for the synthesis of the phosphatidylinoacetylglycan. The membrane anchor that is component of many protein. Without this PIGA tail, this protein cannot express on the surface. This affected protein limit the activation of the complement of the surface of red blood cell. So when there is deficiency of this protein in PIGA precursor, the red blood cell become so sensitive to complement-mediated lysis. So those red blood cells become sensitive to the complement that will lead to the lysis of red blood cells. In PNH, paroxysmal nocturnal hemoglobinuria, the red blood cell hemolysis takes place mostly at the night. when the fixation of complement enhanced, when the blood pH decrease during sleep. Why? Because of the CO2 retention and acid pH induced hemolysis. So this hemolysis of the red blood cell mostly occurs or takes place in the night because of the complement enhanced by the decrease in the blood pH, because the blood pH become reduced as it become acid pH due to what? Retention of CO2 during sleep. The hemolysis induced anemia is less dramatic, but there are other complications include venous thrombosis and infection in such patients. PIGA is X-linked. This is another X-linked anemia or hemolysis that lead to anemia. Thus, normal cells have only single PIGA gene, and the mutation of which is sufficient to give rise to PIGA deficiency and subsequently to the paroxysmal nocturnal hemoglobinuria, in which the hemolysis of red blood cell occurs at the night when the pH decrease because of the retention of the CO2, which lead to the pH of the blood become acidic, and this enhance the fixation of the complement, which lead to the lysis of red blood cell. This is another type of hemolytic anemia that occurs in the fetus. It is erythroblastosis fetalis. What is the erythroblastosis fetalis? When the blood group of the mother is mismatched or incompatible with that of the blood group of the baby, so it will lead to the hemolysis of the red blood cell, subsequently to develop erythroblastosis fetalis. So it is caused basically by the blood group incompatibility between the mother and the child, because the child, especially if the child inherits the red cell antigenic determinant from the father. If the father and the mother have the same blood group, both of them are Rh negative as example, so there is nothing happened, because the fetus and the baby will inherit the same blood group or the Rh from the mother and father, and it is the same, so there is no disease. But if the blood group or the Rh of the father is different from the mother, so this is especially if the mother is Rh negative, this lead to development of or born the baby born with erythroblastosis fetalis. So we have to avoid this disease. Basically, this phenomena because of the leaking of the fetal blood, red blood cell, into maternal circulation during pregnancy or during delivery. For the first baby, when the mother is Rh negative and the baby has different blood group from the mother, so it is rarely or it's not uncommon to affect the first baby, because there is no time for the mother to produce antibody against this baby. But after delivery of the first baby, and when the first baby has different Rh group from the mother, what will happen? The part of the because the RBCs will get into the maternal circulation through the placenta. It is a placental passage of the fetal blood into the maternal circulation, which lead to the production of the maternal antibody. This maternal antibody will be memorized and kept in the blood of the mother. For the second baby, for the second pregnancy, this maternal antibody get and leaking through the transplacental passage into the fetus and cause damage to the red blood cells and then hemolysis, and subsequently lead to the erythroblastosis fetalis. There are two major antigen which is known to induce clinically significant hemolysis is ABO and Rh antigen. The ABO cannot pass through the placenta because they are IgM, while the Rh it is the most harmful, which lead and to the because they are IgG, so it could pass through the placenta and induce hemolysis of the fetal red blood cell. If in case when there is the Rh antibodies of the mother passing through the placenta to the Rh negative to the baby, what will happen? The newborn baby will born with the anemia, jaundice, and the type of the jaundice is very high. Of course, it is unconjugated hyperbilirubinemia, and it might reach 20 milligram per deciliter. This is the risk. This is the dangerous situation. Why? In addition to the hepatosplenomegaly, which is due to the extravascular hemolysis, in addition to the intravascular hemolysis, which is take place in the circulation of the or the blood vessels of the baby, the patient or the baby develop kernicterus. What is this kernicterus? It is a situation in which the bilirubin can pass when it reach 20 milligram per deciliter, but it can pass blood-brain barrier and bind to the lipid in the brain, which result in the brain damage and kernicterus. This is the main dangerous of the baby that born with the Rh negative mother. The anemia also lead to the hypoxic injury to the heart and to the liver and hepatic failure and cause sometimes generalized edema and ascites. The treatment of the baby with the hemolytic anemia. Actually, the baby with the erythroblastosis fetalis, the baby is incompatible with life, so it's die in utero or soon after birth. While all the babies born with with some sort of the jaundice, some sort of physiological jaundice or hemolytic anemia, hemolysis, because there's some sort of the hemolysis because of the high PCV in the blood of the baby because of the PCV high in utero because of the environment is just different from that when get out and was born. So the first line of treatment is phototherapy. يحطون الطفل تحت الضوء وضوء مش عادي ضوء معين in order to dissolve the unconjugated bilirubin and convert it to the harmless water soluble in order not to يقللون التأثير الانconjugated bilirubin يحولوه إلى water soluble one. In severe cases, when the bilirubin reach 20 milligram per deciliter or approaching this figure, we have to exchange of the blood and at the same time give high dose of intravenous immunoglobulin injection. For the mother with Rh negative and given Rh positive baby. If given Rh negative baby, there is nothing will happen because there is no, even the RBCs of the baby get or pass through the placenta, so there is no sensitization because it is the same Rh group. But if the baby born is Rh positive, so there is RBC of the baby will pass through transplacental passage, go to the blood of the mother. Mother will produce autoantibody. This autoantibody will memorize and kept in her blood when she got pregnant for the second baby, and the second baby has different for the second baby, so the autoantibody will get into the if it's Rh positive, so the RBCs will be the antibody will attack the RBC of the baby, and the baby will get severe hemolytic anemia and got erythroblastosis fetalis. What is the treatment in such case? In such a case, the baby the mother should be given during pregnancy, actually basically around the 28th week of pregnancy or according to the decision of the gynecologist, or and within 72 hours before labor to Rh negative mother when she got birth to her first Rh positive baby. Why? In order to prevent the sensitization of the mother, because it needs time. So in the first 72 hours, it is still we have time to prevent this sensitization. نمنع التحسس الأم لكريات الدم الحمر اللي تعبر من البيبي الأول إلى دمها، حتى لهذا نعطيها اللي ال RH immunoglobulin حتى نمنع السنسيتايزيشن. لان في حاله انه ما اعطيناها راح يصير عندها سنسيتايزيشن، حتكون انتي بوديز. الانتي بوديز ممكن يعبر بالبلاسنتا للطفل الثاني ويسبب لنا ارثروبلاستوسيس فيتاليس ويسوي لنا هيموليتيك انيميا. لهذا we have to give the mother anti-D to the mother at the 28th week of pregnancy and within 72 hours before labor to Rh negative mother with the Rh positive neonates. This is the image or the photo of the baby with erythroblastosis fetalis. Actually, it is look at the edema, and baby is jaundice and anemia, and there is a patient. This is because there is, of course, this is this baby is already incompatible with life. Edematous with ascites and hepatosplenomegaly. Look at the distension of the abdomen, and for sure the patient has heart failure, and this is incompatible. This is the feature of the baby with erythroblastosis fetalis, hemolytic anemia due to Rh incompatibility. Traumatic hemolytic anemia. This type of hemolytic anemia, when the red blood cell disrupted by physical trauma in a variety of circumstances, like in the cardiac valve processes, like in صمامات القلب الاصطناعية, or obstruction of vasculatures, such as in microangiopathic hemolytic anemia, malignant hypertension, thrombotic thrombocytopenia purpura, and hemolytic uremic syndrome. All these cases might lead to the destruction or traumatizing factor to the circulating red blood cells, which result in appearance of the red blood cells look like schistocyte, Behr cell, or helmet cell. This is a blood film in patient with microangiopathic hemolytic anemia showing schistocyte. Look at it. Look like schistocyte. شكلها يكون like helmet cell وكأنه مأكولة من كل الجهات. And there is also a nucleated red blood cell, because the nucleated red blood cell already found in the blood film in any case of hemolytic anemia. This is a schistocyte. This is irregular, atypical looking of red blood cells. It look like bitten, look like irregular outline, called schistocyte, and this is helmet, look like the helmet of the soldier. This is also blood film of patient with a microangiopathic hemolytic anemia showing helmet cells and some of the schistocyte here and here, abnormal looking of red blood cell. It look like schistocyte. This is in microangiopathic hemolytic anemia, another traumatic type of traumatic hemolytic. Now we are coming to the lecture 4, in which we will discuss the anemia of diminished erythropoiesis. Anemia of diminished erythropoiesis, including iron deficiency anemia, megaloblastic anemia, vitamin B12 deficiency, and aplastic anemia. Anemia of diminished erythropoiesis. Due to the inadequate dietary supply, as in iron deficiency anemia, or due to the vitamin B12 deficiency or folic acid deficiency, as in megaloblastic anemia, or in pernicious anemia, which is also vitamin B12 deficiency, but it is due to the autoimmune disease, which is due to the production of the autoantibody against the parietal cell in the stomach, with the stomach this parietal cell will produce, which is important to secrete intrinsic factor, which is important in absorption of the vitamin B12. Bone marrow failure also, as in aplastic anemia, included in this category, or the replacement of the bone marrow by tumor or the inflammatory process or by the granulomatous lesion, as in myeloabscessic anemia. First, iron deficiency anemia، يعني فقر الدم بسبب نقص الحديد. This type of anemia is estimated that the anemia that affect about 10% of population in developed country and 25 to 50% in developing countries. Of course, because in developing countries, as expected, that the type of the food or the quality of life, the quality of the food generally is unhealthy because they are focused on the fatty food rather than healthy food, which is rich in iron and other vitamins. But in both settings, the most common cause is iron deficiency. So here in iron deficiency anemia, the most common cause is iron deficiency. It is the most common form of nutritional deficiency. In order to understand the iron deficiency anemia, we have to understand some points in iron metabolism. Generally, the iron total iron in the body is about 2 grams in the women and 6 grams in the men, because you know that the male is different from the female. The male physically are different from the female, muscular mass in the male different from the female, the bone mass in the male are different from the female. In addition, that the female has a periodic monthly period, the menstrual cycle. So this make that there's a difference in between, in addition to the physical difference in between. The 80% of this total body iron, it is functional. The other 20 is stored in the iron pool, which represented by hemosiderin and ferritin. What about the 80% of the body iron that is functional? It is mainly found in the hemoglobin. Therefore, the hemoglobin, when we measure the hemoglobin in the body, it is reflect that the patient, whether he has anemia or not. This is the first figure that reflect that the patient, if he has iron deficiency anemia or not. The first thing to do is to test for the hemoglobin of the patient. What is the remainder of the functional body iron? The remainder in the myoglobin and this found in the muscle and in the iron containing enzymes. Okay. The remainder of 10-20% of total body iron is found stored, مخزونة, in the form of hemosiderin and ferritin. The stored iron mainly found where? In the liver, in the spleen, in the bone marrow and skeletal muscle. The serum ferritin is largely derived from the iron storage pool of iron. So the iron concentration is very important indicator of adequacy of body iron stores. Serum ferritin is very important to reflect if the body stores of the iron is adequate or not, because the iron in the store is very important to be adequate for the patient, for the person, because in any medical condition, in any disease, in any stress and anxiety, this iron stores would be consumed. The iron in the body would be consumed. Therefore, this iron stores should be adequate in order to compensate the loss of the iron, which is burned due to any health problem or medical problem or any stress or any medical situation that any one of us might encountered in our life. So the serum ferritin is very important and good indicator of the adequacy of the body iron stores, which is mainly found in the liver. Also, the other assessment is the bone marrow, also the iron stores, which is another reliable, but this is not the usual way to it is not the usual way to assess the iron stores. However, it is also another reliable, but it is not used because it is invasive method, and it is not and because we have other method like serum ferritin. We just withdraw the blood from the patient and take this the blood sample and then estimate the level of the ferritin. Then we can we could know the level of the ferritin in the body, and according to this reflect the adequacy of the iron stores in the body. Bone marrow estimation of the iron is another way, but is not used because usually not because it is invasive method. This is the distribution of the iron in the body. Here in the macrophage, the amount of the iron in the bone marrow, in the muscle fiber, in the form of the enzyme, and in the form of the myoglobin, as the form of the heme. All of this are distributed according to the amount of the iron in each. Here the iron loss daily 1 to 2 milligram in the form of desquamation of the epithelial cell of GI tract, the absorption from the duodenum. The duodenum is the site of the absorption of the iron. So the absorption daily 1 to 2 milligram daily. And this is all of these are liver, there is 200 milligram. Iron is transported in the plasma by iron binding protein, which is called a transferrin. A normal person, basically the transferrin is about 33% saturated with iron. The serum iron is about 120 microgram per deciliter in the male, 100 microgram in the female. So the total iron binding capacity, when it is estimated, it's ranged between 300 microgram per deciliter to 350. Normally, the iron absorbed in the duodenum of small intestine. Now we are coming now to the mechanism of the absorption of the iron. Non-heme iron, because the heme iron is constituent of the hemoglobin, heme in the hemoglobin, while non-heme iron is carried into the apical and basolateral membrane of enterocyte after it reduced ferrous iron, which is transported by transporter اسمه DVMT1. After transported by this DVMT1 will attach to the ferritin اللي هي mucosal ferritin. وبعدين later on via another transporter اللي هو اسمه ferroportin, the iron move from the intestine cytoplasm to the plasma being oxidized أول مرة تتأكسد by hepaستين and ceruloplasmin إلى ferric iron. Why this mechanism take place? In order to deliver the iron in the form of the ferric to be bound to transferrin in the plasma. Back to the iron mechanism metabolism. Only fraction of the iron that enter the enterocyte being absorbed in the duodenum in the mechanism that we just discussed and then delivered to the transferrin in the plasma. So, where the remainder go? It lost in exfoliated enterocytes. The iron absorption regulated by hepcidin, this synthesized in the liver, inhibit the iron absorption. We said inhibit the iron absorption when the blood iron is increased. Ferroportin enhance iron absorption by enterocytes. and the transfer of the iron into the plasma, transferrin. So it is enhanced when there is iron deficit or erythropoiesis is inefficient or ineffective. This diagram showing the iron absorption in the small intestine that we just discussed. Look at here. Heme in the iron, in the food, non-heme iron, after reduction, absorption by this DVMT1, transport into the mucosal ferritin, from the mucosal ferritin through the ferroportin, it will transfer it to the transfer this ferroportin will take the ferric and بعد أن يoxidize by هيباهاسيتين، يعني هذا يأكسد الحديد، وهذا in order to be transformed من Fe plus 2، لأن هنا الحديد من كان Fe plus 3 reduced to Fe plus 2. لما اختزل إلى ال Fe plus 2 وين صار؟ in order to be reabsorbed to absorbed من الانتستين من الانتروسايت by DVMT1 وين يروح للميوكوزال فيرتين، بعدين وين يروح؟ عن طريق الفيروبورتين بعد أن يتأكسد من Fe plus 2 إلى Fe plus 3 عن طريق هذا اللي أكسده وسيروبلازمين أيضا سيروبلازمين in order to bound with plasma transferrin اللي هو هذا البروتين اللي in order to be delivered in the blood, because iron alone cannot be delivered. No free iron should be bound to the plasma transferrin. Coming now to the causes of iron deficiency anemia. The most important cause, and the commonest cause actually, is the food. Food is poor in iron. Iron poor food, malnutrition, kwashiorkor, مجاعات, الفقر, poverty, vegetarian's diet, الناس اللي تاكل بس خضرة ما ياكلون لحم, الفقر. This is the first cause of the iron deficiency anemia. طعام, unhealthy food, not rich in iron. Food, poor in iron. The most commonly due to the poverty, actually. الفقر. The second cause, malabsorption. No, there is the people have good meals, but there is problem in absorption. There are certain diseases that prevent the absorption of the iron in the intestine, such as in celiac disease and gastrectomy. Therefore, nowadays, which is one of the morbidities or the hazard that carried out after or they happened after gastrectomy, plastic surgery that done by hundreds and thousands of population, especially obese patient, in order to reduce their weight. So what they do? Surgical removal of a part of the stomach. Actually, this gastrectomy will affect the iron in the body. It will decrease the iron, and most of these patients will suffer after the surgical operation from the iron deficiency anemia and other vitamin deficiencies. The other cause is increase in the demands, as in the pregnancy, in the labor, in the infancy. Of course, in the pregnancy, therefore, most of the pregnant females have iron supplement during the pregnancy and also after labor. Or sometimes the people have chronic blood loss. What is the meaning of this? Patient might have gynecological bleeding, menorrhagia, irregular menstrual cycle, spotting, might have GI tract bleeding, peptic ulcer, duodenal ulcer, ulcerative colitis, might be due to the cancer, or a hemorrhoid that bleed infrequently now and then. All of these GI tract disease, all of them might contribute to development of iron deficiency anemia and considered as the one of the causes of development of this type of anemia. This is actually the microscopical view of the iron deficiency anemia. Look at it. Look at the size of the RBCs. At the same time, the shape of the there's anisopoikilocytosis, hypochromic microcytic. Look at the size is very small. They are smaller than normal. However, this is the other population of this is dual population, but sometimes there's overlapping, so it appear like normochromics. But generally here, this is hypochromic microcytic anemia, which is the main characteristic feature of the iron deficiency anemia and peripheral blood film. The blood film, this is the blood film in an iron deficiency anemia. You can see the size and the shape of red blood cell, mild anisopoikilocytosis here, and there is hypochromic microcytic. We can see that the red blood cells are clearly and hypochromic and microcytic. The size of the cell are small, and the amount of the hemoglobin apparently it is hypochromic. So this type of the anemia is hypochromic microcytic anemia. The bone marrow in patients with iron deficiency anemia is hypercellular, showing erythroid hyperplasia. The peripheral blood show microcytic. The size of the cells are small, hypochromic, the less amount of the hemoglobin, so it's become hypochromic. Red blood cells, mild according to the severity of anemia, moderate poikilocytosis and anisocytosis. Sometimes few target cells are found in the peripheral blood film, so it's not so trying to find some of them. And there is increased reticulocyte count because of the erythroid hyperplasia. With severe iron deficiency anemia, sometimes we found that the peripheral blood film, in addition to the hypochromia and microcytic microcytosis, we found pencil-shaped cell and sometimes small number of nucleated red blood cells, normoblast yani. The hemoglobin is reduced when we do the CBC, complete blood picture. We found that the hemoglobin level is reduced. To confirm the diagnosis of iron deficiency anemia, there are certain important tests which should be done, include serum ferritin, serum iron, transferrin, and iron binding capacity. This is a peripheral blood film which showing microcytic hypochromic anemia. Look at these. Mild anisopoikilocytosis, not so severe actually anemia, pencil shaped, moderate. Maybe this may be moderate, not so severe, not mild. It's moderate anemia in severity. This is hypochromia. Look at this hemoglobin, very less amount of the hemoglobin, and the small size of the red blood. Clinically, most of the patients with iron deficiency anemia are asymptomatic, no symptoms, unless they develop severe anemia, in which there is non-specific manifestations such as weakness, tiredness, pallor, pale face, their face are pale, sometimes easy fatigability during on exertion, on exercise, palpitation, what else? Loss of appetite sometimes. In long-standing severe anemia, there are other features that might develop on the patient, such as thinning and flattening, spooning of the fingernails, called koinonia. And there are sometimes appear there are certain peculiar behavior that the patient like to consume or eat non-food stuff like dirt, like clay. يعني يحب ياكل الطين أو الديرت، أو يحب يحفر الحيطة حتى ياكلها. عندهم دول البيشنت اللي عندهم ايرون ديفيشنسي انيميا، عندهم هذا الديزاير، ما معروف شنو السبب. ممكن يكون نقص الحديد يجعله eager to eat clay اللي هو الطين. This is koilonychia. It is nail spooning, which is seen in severe case of iron deficiency anemia. Look at spooning of it. This is a glossitis also. We can see that the patient have a glossitis in patient with iron deficiency anemia, other feature that might be seen in severe iron deficiency anemia. This is also chelosis. Chelosis, this is fissuring in the angle of the mouth, which is the another feature of the iron deficiency anemia because it's affect the integrity and the texture of the skin, so become fissuring here. Diagnostic criteria of iron deficiency anemia, as we just mentioned in the previous slides, is include complete blood picture. We do the completed blood picture, which is very important, CBC, which include hemoglobin, level of hemoglobin, MCV, MCH, mean corpuscular volume, mean corpuscular hemoglobin. Hemoglobin usually reduced in anemia below normal level according to the age, according to the sex, because in male are different their normal reference range from the female. And mean corpuscular hemoglobin also reduced. Mean corpuscular hemoglobin concentration, MCHC, also reduced. Sometimes the peripheral blood form showing hypochromic microcytic with other features that is discussed in previous slides. Increase in the platelet count, sometimes erythropoietin increase of the level. Also, serum ferritin low, decrease, reduced. Serum iron level, low transferrin saturation, increase in the total iron binding capacity, and finally the response to iron therapy by increase in the reticulocyte count. We can see that reticulocyte count increase. That means the patient is responding to iron therapy. Anemia of a chronic disease. This type of anemia is important, and it is the most common form of anemia, especially in hospitalized patients. Superficially resemble the anemia of iron deficiency, but it stems from the inflammation, which induces sequestration of iron within the cell of the mononuclear phagocyte in reticuloendothelial system. This type of anemia, anemia of chronic disease, occurs in a chronic microbial infection, such as in patients with osteomyelitis, bacterial endocarditis, lung abscesses, in a chronic immune disorder, such as in rheumatoid arthritis and regional enteritis, and in the neoplasms or in malignant lymphoma, as in Hodgkin lymphoma and carcinoma of the lung and the breast. In this type of anemia, the patient presented as any type of anemia, which is pallor and weakness and fatigability and tiredness, or sometimes loss of concentration. The red blood cells showing microcytic hypochromic anemia in peripheral blood film. Serum iron level is low, and the iron storage in the bone marrow is increased, not like iron deficiency anemia in which the iron storage in the bone marrow is decreased. Why here the iron storage in the bone marrow is increased, which is presented by the numerous hemoserine-laden macrophage because of the sequestration of the iron in the macrophage and reticuloendothelial systems. Serum ferritin, in such a case, concentration is elevated. Iron binding capacity is reduced. This is the difference in between the iron deficiency anemia, pure iron deficiency anemia, and the anemia of the chronic illness, in which the iron binding capacity is reduced, serum iron is reduced, hemoglobin also reduced, but the serum ferritin concentration and the storage of the iron in the bone marrow, in the hemocyte, which is showing by hemocyte-related macrophages, are increased. The pathogenesis of the anemia of chronic illness. This type of anemia stems from the high level of the plasma hepcidin synthesis from the liver. This blocks the transfer of iron from the jejunal mucosa to the erythroid precursors by downregulating ferroportin. In such a case, that elevated hepcidin level induced by interleukin 6, which is produced by the macrophage during the inflammation, which increases the hepatic synthesis of the hepcidin. This interleukin 6 is produced by the macrophages during the inflammation, especially the chronic inflammation, this which increases the hepatic synthesis of hepcidin. Subsequently, the increased level of the hepcidin, it will block the transfer of the iron from the jejunal mucosa. Have you seen this vicious circle of the absorption of the iron, which is inhibited by the increased synthesis of the hepcidin in order to decrease the level of the iron in the body? In addition to this, the chronic inflammation blocks erythropoietin synthesis by the kidney, thus it lowers the production of red blood cell by the bone marrow. Now we are coming to the other type of the anemia, which is called megaloblastic anemia, due to the vitamin B12 and folate deficiency. Megaloblastic anemia, it is two forms of anemia, include pernicious anemia, which is caused by the vitamin B12 deficiency, or due to the anemia caused by the folate deficiency. Both vitamin B12 and folic acid are coenzymes in the DNA synthesis pathways. What does that mean? Vitamin B12 and folic acid are important factors in synthesis of the DNA. So the deficiencies will lead to the impairment of the DNA synthesis. Subsequently, it will lead to the distinctive, striking morphological changes in the peripheral blood film and in the bone marrow. The vitamin B12 deficiency is caused by pernicious anemia. What is the meaning of pernicious anemia? As I think I mentioned this type of anemia in some of the previous slides. When there is autoantibody against the parietal cell in the stomach, the intrinsic factor seen in autoimmune gastritis, because the vitamin B12, when absorbed, need intrinsic factor. The intrinsic factor is produced by the parietal cell. When there is autoantibody, that means that the body secretes antibody against its own parietal cell. So this will lead to the malabsorption of the vitamin B12. So this autoantibody, it is important in the pathogenesis of the vitamin B12 deficiency anemia, and it is detected in the serum and gastric juice of the patients. Other type of the malabsorption syndrome that also and the disease that involved the small intestine, especially at the ileum, because the ileum is the site of terminal ileum is the site of the absorption of the vitamin B12 when combined with the intrinsic factor. So when there is any disease involving this part of the small bowel, it will affect the absorption of the vitamin B12 and intrinsic factor complex and subsequently it will lead to the development of the megaloblastic anemia. But the megaloblastic anemia to develop need long time to develop. The onset is insidious. It is gradual. It is not sudden onset of development. The pathogenesis of the megaloblastic anemia, the morphological hallmarks, the morphological finding, the important morphological finding in megaloblastic anemia is the enlargement of the erythrocyte precursors, which is called megaloblast. تصير كبيرة. The cells appear giant-like, very large, called macrocyte or megaloblast, the precursors of the erythrocyte. Then giving rise to what? To the large erythrocyte, large red blood cells, which is called macrocyte, which is thought to be related to the defective in the red blood cell maturation and division. The other myeloid lineage are also affected. It is because the vitamin B12, it is affected the DNA synthesis. So it is not only the erythroid precursors will be affected, or the erythroid lineage, the myeloid lineage and the other, also the platelet will be affected. So the granulocyte precursors enlarged, and it is appear as giant عملاقة metamyelocyte, which yield highly characteristic hypersegmented neutrophils. It gives rise to the hypersegmented neutrophil, which is a characteristic feature of the megaloblastic anemia in the peripheral blood film. The platelet also affected. The platelet appear, the precursor of the platelet, which is giant megakaryocyte. The patient also might develop pancytopenia, anemia, leukopenia, and thrombocytopenia because of ineffective of the production of the bone marrow, because of the impairment of the DNA synthesis due to the vitamin B12 or folate deficiency. Deficiency of those vitamins actually, which result in defective in the nuclear maturation. This is due to the delay or reduce in the nuclear DNA synthesis, because the vitamin B12 and folate is important in the nuclear DNA synthesis, which lead to the delay in the nuclear maturation and subsequently the cell maturation and division. The synthesis of RNA and protein is unaffected. The affected only the the maturation and cell division, because it affects the nuclear DNA only, while the cytoplasm, the RNA, and the protein is not affected. Therefore, the cytoplasm enlargement is not matched by DNA synthesis, and so there is delay or block in mitotic division. Thus, there appear to be asynchrony. Asynchrony, what does that mean? Asynchrony, that to say there is يعني إنه المaturation of the cytoplasm يختلف عن المaturation عن للنيوكليوس للنواة. يعني asynchrony، ماكو توافق. There is no synchronization in the maturation between cytoplasm and maturation of the nucleus. This is called ineffective hematopoiesis. So the any red blood cell or the platelet or the myeloid or the neutrophil that produced by the hematopoiesis is ineffective because of the defective in the DNA synthesis. Morphology. In the peripheral blood film, we see there is marked variation in the size and shape, anisopoikilocytosis. When there is marked variation in the shape, we said it is poikilocytosis, while marked variation in the size, it is anisocytosis. Red blood cells are normochromic but macrocytic. The mean corpuscular volume is 110, normally between 82 to the 92. So it may look like oval or round, and the nucleated red blood cells are also seen Why also seen? As we know that in nucleated red blood cell, when there is erythroid hyperplasia, increase the production of the bone marrow, shifting of the and shedding of the some immature red blood cells into the peripheral blood is seen. The neutrophils also are larger than normal, and it is appear as hypersegmented, which contain more about 5 to 6 lobules. In addition to all of these, there is leukopenia and thrombocytopenia. This is a microscopical view of the at the left of the normoblast, normal precursor of red blood cell, while here there is a what is here? There is megaloblast in megaloblastic anemia. Here is normal. This is a normoblast, normal looking, while here in the right, the megaloblast which show enlargement of the erythroid precursors because of the defect in the DNA synthesis due to the vitamin B12 and or folate deficiency. This is also megaloblast in the bone marrow aspirate. Look at it. It is very large cells with enlargement of the nucleus. However, the size of the cytoplasm is normal because the RNA and the protein is unaffected. The affected only the increase in the size of the nucleus because of the impairment of the DNA synthesis. In this blood film, we see that the megaloblastic anemia showing immature nucleated red blood cell. This is immature nucleated red blood cells. And this is a normal red blood cells. And those are the immature nucleated red blood cells. Here, which is the so distinctive feature of the megaloblastic anemia in the blood film, it is hypersegmented neutrophil. It's about 5 to 6 lobule, which is more than normal looking neutrophils. It is seen, this hypersegmented neutrophil, it is seen in megaloblastic. This is a microscopical view of the bone marrow aspirate in the megaloblastic anemia, which showing giant metamyelocyte, which is a precursor of granulocyte. The bone marrow examination in patient with megaloblastic anemia, we will see marked hypercellular bone marrow showing increase in the number of the megaloblast. They are larger than normoblast, and they're showing fine nuclear chromatin and basophilic cytoplasm. The cytoplasm looks well hemoglobinized, but the nucleus failed to show chromatin clumping because there is asynchrony in between the maturation of the cytoplasm and maturation of the nucleus. Not pycnotic as in normoblast to create nuclear cytoplasmic dissociation, which is a characteristic feature of the megaloblastic anemia. The granulocyte showing nuclear cytoplasmic asynchrony, yielding giant metamyelocyte. And also the megakaryocyte are large and giant in size and bizarre with multi-lobated nuclei. The clinical features of the patient with megaloblastic anemia: pernicious anemia and with vitamin B12 deficiency, which is due to the autoimmune antibody that is produced against the parietal cell, which is the important to secrete intrinsic factor. So the clinical feature characterized by it is insidious onset, as we said. It is not acute onset nor abrupt. It is insidious. It is need time, long time to develop the vitamin B12 deficiency. Pallor, weakness, easy fatigability on exertion, dyspnea, all of these are the features of anemia. The blood film, as we said and as we seen in the previous slides, moderate to severe megaloblastic anemia, hypersegmented granulocyte, leukopenia, moderate to severe thrombocytopenia. There is a neurological changes. In vitamin B12 deficiency, it causes demyelination of the lateral posterior column of the spinal cord. In time, axonal degenerations may supervene, causing weakness. This is the main important effect and the bad effect of the vitamin B12 deficiency, in which it will lead to the demyelination, loss of the myelin of the axons in the lateral posterior column of the spinal cord. So this leads to the weakness, numbness, tingling sensation of the hand and feet, and unsteadiness in the gait or in the when the patient walk. This is called subacute combined degeneration of the spinal cord, which is caused by the vitamin B12 deficiency as a result of the pernicious anemia due to the demyelination of the lateral posterior column of the spinal cord. While in the folic acid deficiency, which is less common than the vitamin B12 deficiency, the risk is high among those with a poor diet, among those with poor communities, when there is increase in the metabolic demand, such as in the pregnant women. Therefore, in each pregnant woman should be given the folic acid from the early days of her pregnancy. The clinical and hematological features are the same of the vitamin B12 deficiency, but without neurological features. The diagnosis of the vitamin B12 deficiency or the megaloblastic anemia depend on the history of the patient, that given patient and the physical examination, the patient feel tired, look pallor, and feel loss of concentration, loss of the memory, or sometimes he is insomnia. He told the patient that his internist or the physician that he forgets certain things, certain names, some of the names, so or the dates. So according then the internist will send the doctor the patient into the to do a complete blood picture and do hemoglobin, which is reduced, but we will see that mean corpuscular volume is also decreased. The peripheral blood film showing megaloblastic anemia, there is megaloblast, and showing that the macrocytes and the red blood cells and also hyper-segmented neutrophils are seen in the peripheral blood film, while the bone marrow showing megaloblast, large normoblast, and also giant megakaryocyte. The level of the vitamin B12 is low. There is a range in the vitamin B12. It's between 200 to the 1000. So below 200 considers that patient has deficiency in the vitamin B12 and should be given injection of the vitamin B12 injection should be given in order to replace the deficiency in the vitamin B12. The serum antibody against intrinsic factor in case of the pernicious anemia, when there is autoantibody against the parietal cell, so we will find it in the serum of the patient. We will if the patient given the vitamin B12 injection in case of deficiency, we will see that dramatic increase of the reticulocyte in the blood within 2 to 3 days. That means that the treatment of such patient is successful. Now we are coming to the new topic, which is aplastic anemia, which refer to the disorder that involved multipotent myeloid stem cell. All the type of the element of the blood are affected. The myeloid stem cells are suppressed, which lead to the marrow failure and pancytopenia. What is the meaning of the pancytopenia? Pancytopenia, in which there is anemia, leukopenia, and thrombocytopenia. Hemoglobin anemia, reduced in the red blood cells, reduce in the white blood cell leukopenia, and reduce in the platelet count, thrombocytopenia. Most of the cases, aplastic anemia is idiopathic and non-cause. We don't know the underlying cause of this type of anemia. However, there's certain myelotoxic agents, such as the drug that are used in treatment of cancer, or certain chemicals that lead to the marrow damage, and it is dose related. It is related to the dose that patient take, and usually reversible. When we withdraw the drug, that cause this marrow damage, the marrow will get back to its normal condition and normal productive activity and the function. However, the idiopathic is more the poor prognosis, of course, because we don't know the cause of this type of anemia. What are the drugs that are lead to the marrow failure and pancytopenia? Anti-cancerous drug as alkylating agent, antimetabolites, benzene, or idiosyncratic or hypersensitivity reaction, which is non-dose related. That means the patient is sensitive to even small doses, such as of the myelotoxic drugs, such as clonfenicol, sulfa drugs, which are not myelotoxic in other persons. But those patients, certain patients, are hypersensitive or yes, hypersensitive to the even small amount or small doses of these drugs. The other cause which lead to the damage to the bone marrow and marrow failure is a viral infection. Most commonly is community acquired viral hepatitis type A or B or C. Morphology. What will we see? What will bone marrow or the peripheral blood film show in aplastic anemia? In the bone marrow, there's in patient with aplastic anemia, it is markedly hypocellular, decrease all the component of the bone marrow, and replacement about more than 90% of intertrabecular space replaced by fat or occupied by fat. The limited cellularity only to the lymphocyte and plasma cell. All the components of the bone marrow and elements are decreased or reduced or sometimes absent. These changes, of course, it is better appreciated in bone marrow biopsy specimen than in marrow aspirate. Why? Because it is showing a dry trap. When we try to aspirate blood, because the bone marrow, 90% of it is occupied by fat, but there is nothing when we try to aspirate. So it's better for the better for those patients to be diagnosed by bone marrow biopsy. There are a number of secondary changes often accompany marrow failure. Anemia may lead to the fatty changes in the liver. Thrombocytopenia and granulocytopenia may result in, of course, hemorrhage, petechial hemorrhage, or frank hemorrhage, bleeding, and of course, granulocytopenia lead to the repeated bacterial infection, and the patient in aplastic anemia become immune compromised and susceptible to various types of the infection. Requirement of the transfusion, because there is depletion of the all elements of the blood, so it need repeated blood transfusion, which eventually may lead to the hemocirrhosis. This is a bone marrow, which is showing the hypocellular bone marrow. Actually, more than 90% of the bone marrow in patient with the aplastic anemia occupied by fat. The cellularity is just confined to the plasma cell and the lymphocyte. The predominant cells is fat cell, and very scanty hematopoietic cells are seen. This is a blood film showing that in blood aplastic anemia, showing normochromic normocytic anemia. There's the red blood cells showing normochromic normocytic, and the platelet decrease in the number of the platelet. Actually, there is no platelet or just one platelet seen here. And there is in this blood film there is no granulocyte or there is no white blood cell are identified in this blood film. These pancytopenia, anemia when reduced in the hemoglobin, pancytopenia including anemia and leukopenia and thrombocytopenia. Clinical course. It may affect person of all age and both male and female. Slowly progressive anemia. So it is the insidious development of the weakness, of the pallor and dyspnea. Of course, this is the clinical symptoms that accompany anemia. Type of anemia in this patient is insidious. Thrombocytopenia, it is patient is presented with petechiae, ecchymosis, which is bruises, blue bruises in the skin, when he easily, even without any trauma, at the site when there is it's not exposed to the trauma. Petechiae, there's pinpoint bleeding spots, petechiae and purpura. I think in the previous or in the first term, we have discussed the thrombocytopenia and the type of the petechiae and the purpura, how is the difference in between, and the ecchymosis that is seen in the skin of the patient with the thrombocytopenia, which is decrease in the platelet count. A granulocytopenia means decrease in the number of the leukocyte or the white blood cell, which is manifested only a frequent and persistent minor infection. Patient has low immunity, so there is patient may develop fever, chills and fever and prostration and all the signs of the infection. And it is maybe repeated upper respiratory tract infection with mild illness. The patient cannot resist this microorganism or the bacteria or the persistent and repeated viral infection. Splenomegaly is characteristically absent in aplastic anemia. So what is the type of the anemia that characteristically the splenomegaly is absent? So it is in the aplastic anemia. It is present. If it's present, the diagnosis of the aplastic anemia should be seriously questioned, because this is one of the characteristic feature of the aplastic anemia. Red blood cell normochromic normocytic, although slight macrocytosis might be seen, and reticulocyte also reduce in number because the bone marrow is non-functioning. Bone marrow replaced the most of the bone marrow replaced by fat, so it is inactive. Therefore, the reticulocyte, which is the immature red blood cells which appear in the blood of the patient with the active bone marrow, is not seen in patient with aplastic anemia. Pathogenesis. The events that lead to the bone marrow failure remain vague. 70 to 80% of the cases with aplastic anemia respond to immune suppressive therapy aimed at T cells. So that means that autoreactive T cell may play important role. When immune suppressive therapy are used and respond the patient with aplastic anemia, 70 to 80% of them respond to this treatment, mean this disease is mainly due to the autoimmune mechanism that is run in the body of the patient. So autoreactive T cell may play an important role. Small fraction of the patient with acquired aplastic anemia have inherited defect in telomerase. This is needed for the maintenance and stability of the chromosome. So this defect might lead to the premature senescence of the hematopoietic stem cell, premature death or a premature stop of the activity and replication of the hematopoietic stem cells. A small fraction of the patient have inherited defects in the telomerase, the enzyme that are required for the maintenance and stability of the chromosome. Prognosis of the patient is quite unpredictable. Withdrawal of toxic drug may lead to the recovery and the bone marrow reverse to its normal. Idiopathic, of course, because it is unknown mechanism, and at the same time, mostly commonly it is due to the autoimmune or autoreactive T cells. Therefore, the prognosis is they carry poor prognosis, especially if left untreated. The bone marrow transplantation is the one of the most important and extremely effective mode of treatment or the therapy, especially if it is performed before the age of 40. Patients who are poor transplant may benefit from the immune suppressive therapy.